All right, good morning, everyone. Good morning. Thanks for attending. I'm David Fideli. I'm a psychologist at the University of Florida. I'll be moderating the session along with Claire Hageland, who's at the Children's Hospital of Michigan. We're happy with the turnout. We do have seats for those who want them up front. Feel free to come sit if you'd like it. We're just going to give a brief orientation and then jump right into the talks. But thanks for everyone's interest in today's session. We're really excited about it. Claire and I don't have any disclosures. So here's just a brief reminder of the learning objectives today. So we're hoping that you'll leave here with understanding sort of cutting edge science and developing and testing interventions to improve psychosocial outcomes for people with CF, identifying methods to develop and validate some measures, some newly developed measures that I think we'll be all using hopefully in the near future in our clinics, and also thinking about EPIC integration for screening strategies for kids who are younger with CF. So here's our 5 awesome presenters in the order that they'll be going in the titles of their talks. So we're going to get started with Brandy here in one moment, and then jump to a screening presentation by Susan Moore, a validation study by Carolyn Snell, and then 2 different randomized control trials, one in CBT with Deborah Friedman, and then one with ACT with Virginia O'Hare. So without further ado, we will get started. Just some housekeeping. We're going to have about 15 or so minutes for each presenter. We'll have some time for questions and answers individually for each of them. Please, if you don't just want to hear the prepared questions that Claire and I created, which are great, I promise, then, but we'd rather not, then submit questions. You could either come up to the mics, that's fine, if you want to do old school, or submit something through the app. That's also okay, and we'll be monitoring that. And we will have maybe some time at the end for some just other conversation, time permitting. Okay, all right, thanks so much.
Okay, so as a reminder, only you all can save everyone from our questions. So you have some great presentations to look forward to, and I'm sure it will generate some very rich questions and discussion. But without further ado, our first presenter is Brandy Middour-Oxler.
You got it right, yeah.
She is from Emory University, and she is going to be presenting today about ADAPT-CF, a little bit about Brandy. She is faculty in the School of Medicine at Emory University in Atlanta, Georgia. She's also a pediatric nurse practitioner and the center's transition program coordinator, because that's not a lot. Her research interests include transition to adult care, relationship-centered communication, and addressing distressing symptoms and care involving people with CF. Wow. And in her free time, she's also a trainer for the Partnership Enhancement Program, or PEP, for the Cystic Fibrosis Center. So, Brandy, everyone.
Thank you so much, everybody. And I just wanted to acknowledge this is the work of a much larger group. Some of the authors for our poster I have listed here, it's poster 504, if you'd like to stop by as well. Okay, there are my disclosure slides. And a little bit about the agenda, or no, yes. So I'm going to talk a little bit about our background and goals when we started this project, the development. We had a multi-phase development with so many people involved. I see quite a few of them in the room, and I'm so thankful for all of you. And then talk about our pilot test with ADAPT-CF and then future directions as well. But I also need to really acknowledge the larger work here with improving life with CF, the primary palliative care partnership. There are so many great resources on improving life with CF.org. Free CEUs, webinars, all CF-specific palliative care information by our wonderful Anna Georgiopoulos and Laura Dingra. So if you would like free CEUs, great information on CF-specific palliative care, you can find it at this website, as well as ADAPT-CF. So a little bit of background. As everyone knows, in 2021, the CF Foundation released the palliative care guidelines. And in those guidelines, it said that children with CF, 12 and younger, and their family members should really be screened to address the multiple sources of illness burden. And we should do that using the Integrated Palliative Care Outcome Scale, or IPOS for short. And I have to be honest, when I read that, the IPOS is not a validated instrument for 12 and younger. So as a pediatric nurse practitioner, I'm reading this going, that sounds so fantastic. How on earth am I ever going to do that in my clinic? And it sounded like a really, really big project, or a big problem. So a little bit about the IPOS. I'm sure many of you know the Integrated Palliative Care Outcome Scale is validated in 12 and over. It covers these domains: physical symptoms, emotional symptoms, communication needs. Do you have enough information? Are you sharing feelings the way that you would like? It also covers practical issues, which I love. We need to talk about practical issues. And then spiritual and existential issues. So these are all the things that we needed to keep in mind in talking with people under 12. So I wanted to really discuss that. We also had questions: can we talk to children under 12 about their spiritual needs? And I've got great information on that a little bit later as well. So after I said, how on earth are we ever going to do this? This sounds impossible. About a week later, Anna Georgiopoulos came to me and said, Brandy, could you write a communication guide to do all of those things? And I thought, that's what I get for putting that out in the universe. But I figured if I had a need, all of you had needs too. And so even though I didn't know how I was going to do that, how our group was going to work together to do that, I said yes. So our goal was to write that CF-specific pediatric palliative care interview guide to really help support all of us in clinic, to support our patients and families. It needs to cover those domains that I discussed in the IPOS, yet somehow make them CF-specific. So what needs to be added for CF, what needs to drop off that doesn't impact our patients, and then magically have age-appropriate language too for children because they think so differently, and for it to also be age-appropriate in length as well. So those were kind of all the things that I was trying to process and our group was trying to process at the time. So doing this, we came up with a child cognitive approach to really think about those age groups. We divided it out in 0 to 3, 4 to 6, and 7 to 11 years old. It was important really to think about who we should address those questions to. So for the older two age groups, the questions are always addressed to the children first. It's so important to really get them thinking about what's impacting their life, to really think about being an activated adult that really talks to their clinicians. But then for that younger age group, the questions really are first geared to the parent. If you had a really verbal child, you can try with them, but it's going to be a little bit more difficult. So in the development process, Dr. Rachel Linneman and I first sat down using that approach and wrote questions for each IPOS domain within those age groups. Then we took it to our fantastic mental health coordinator, Shayna Blair, and our social workers in our center. One step I took in here that's not actually documented is my best friend is a mom of a child with CF, and her mother-in-law was diagnosed many years ago too. Her husband just had a positive sweat test. And so I went to her and said, Shelly, what do you think about this? And she said, oh my gosh, Brandy, these are all the questions I, as a mom, want to know about my kid. So it made me also feel really, really great about it. So after we tweaked these questions, we then took it to our diverse family advisory council. I feel committed about really representing and going back to them at every step. And honestly, we were afraid, what are they going to say when we say palliative care? Is that the voodoo word? And to our surprise, they said, this is fantastic. Please have these conversations with our children. And so we kept moving along. Then I presented ADAPT-CF to our multi-site expert panel of clinicians, of palliative care experts, community stakeholders, and got feedback and really adapted the questions. And then that resulted in our final communication guide, and I named it the Assessing for Distressing Symptoms and Palliative Care Needs Through Targeted Conversations, or ADAPT-CF for short. But we weren't done. Just as another layer of development, we did a Delphi survey with people that are communication experts. I leaned on my PEP, the Partnership Enhancement Program communication trainers. Many of them are faculty with the Academy of Communication and Healthcare, but they're also providers of CF, and we had one parent partner that's also a trainer. They had a mean of 19 years in practice, and it really spanned every multidisciplinary team member you can imagine, including child life. And that resulted in small wording changes, adding probes and small edits, but the overall feedback was very positive. And the experts really stated, move forward with this. And they thought that it could really help empower children with CF towards self-advocacy as well. So after that, we piloted it. Our mental health coordinator, our social worker, and I piloted ADAPT CF with 19 patients and families. Of course, all the patients were under 12, but they averaged about 5 years in age. We had a good mix of male and female, although slightly more, 52% were female. And you can see that most of the assessments obtained information from the patient and the parent, about 63% of them. 5 involved the parent or guardian only, and 2 involved the patient only. But great news for us, we were trying to monitor for, are any of these questions distressing to these children? And our patients and families told us no. So we also wanted to know, is this going to be good to use in clinical practice? How much time is this going to take? And the great news is that it took about 13.6 minutes on average to administer. The range was 5 to 25 minutes because we got some rich data and had some great conversations with a few of our children. And to our surprise, we found almost 58% of our children had needs that we did not previously know about. So I'm going to talk a little bit about those needs right now. So in those needs that we found, 42% were emotional symptoms, 26% were physical symptoms, and then we have an even breakdown, the 5.3% of spiritual or existential concerns or needs, information needs, just wanting to understand more about CF or their treatment, and then the need for further support. One of my favorite questions that I have the most questions about, is this going to work with young children, is a question that asked, you know what it means to be at peace? And I had a lot of concerns, is this really going to work? And for the most part, it did. One of our children actually drew a picture of what it meant to be at peace. And so this is crayon on paper towel in clinic. And this young girl told me, yeah, Brandy, I know what it means to be at peace, but I want to draw a picture. So for her, she said, being at peace, you feel all fluffy inside. It's not exactly like joy. It's not exactly like happiness, because oftentimes it happens after you're with the people you love. And she said it kind of comes off of you like rays. It's interesting to note, people in this picture, she said, are the people that help bring her peace, but one of the persons is not even really in her life. Just the memory and the thought of them brings her peace. And I don't know if you can tell in here, but there's no legs. And I said to the patient, oh, do you need a moment to draw legs? And she thought about it and she said, no, Brandy, because peace is not in your legs, it's all here. And I think she's right. So the feedback from our providers is that most people felt very comfortable using it. It was somewhat easy to use and very effective at having these conversations. And based on these findings, again, we made small changes to ADAPT CF. So after our pilot, ADAPT CF was rolled out to 5 care centers in the U.S. It's been in use for about a year, but we really feel that this may help facilitate really great conversations, identify unmet needs in patients 12 and under and their family members with CF. We also think it can really increase the acceptability and the effectiveness of screening and help to standardize across programs and providers. And it's also, we have a UK English version. We're working with a group in the UK who's rolling this out for their yearly screening as well. This is what ADAPT CF looks like really quickly. It is beautiful. The marketing department has done great. One of my favorite things is there's an intro for care teams that helps guide your care team on our thought process. There's also an intro for parents, guardians, and family members as well. And this is a little bit about what the 0 to 3-year-old age group looks like. But again, improvinglifewithcf.org, we are committed to this being free to everyone. There is no charge. I am committed to making this available to everyone because as a provider, I hate it when there's a paywall when I want a resource. And a special thank you to our collaborators at all of these centers here. I couldn't have done it without you. And that's it.
Okay, so we have some time for questions. I'm going to check the app here. So please feel free to submit them. I can get us started though.
Yeah.
So Brandy, I was hoping that you could maybe spend some time just sharing when, like in terms of implementation in clinics, if you all have advice on when care teams should be having these conversations, and are they continuous, are they single time, and who on the care team do you think is best equipped or you would recommend to have the conversations?
Great question. And I think we have to flex a little bit to the makeup of our care teams. Luckily, the questions and the amount of time it takes, they're all open-ended. They are questions that are easy to ask. I think some care teams want to put this on our social workers, but I want to really challenge providers as well to have these conversations. There is so much value and so much relationship building that goes into this. If you've done any of the PEP training, there's also a rapport building question at the beginning. And so I think it would really not do everyone's skills justice to think that everyone is not capable of using the guide and getting all of the answers and the relationship building as well. As far as when to use it, so our clinic has decided to do this annually and again with triggered events. And it may make a difference what you think is a triggered event. Maybe it's a hospitalization. Maybe it's a new Pseudomonas. Maybe it's a drop in lung function where you are considering lung transplant. But it's really a collaborative process that I think anyone on the care team should be activated and empowered to say, hey, I think maybe having ADAPT CF here today would be helpful.
I can be loud. My question, kind of jumping off of what David just shared, so you do the annual screening and some interesting information comes out.
Yeah.
How, or I guess what suggestions do you have around how to maybe sell how important this tool is to maybe members of the care team who might not view conversations around spirituality and pediatric populations as being something that belongs within CF clinic?
Yeah, that's a great question. So I think we have to think more about what as a team we value and what our patients value. And for some patients, maybe it's not a religion, maybe it's a spiritual connection, maybe it's, leaning into their mind-body connection. But when you ask those open-ended questions, you're more easily able to understand and value what's important to them. And they're the ones telling you, like, I do think maybe this is missing in my life. And so I love it in a way that it's not our values. We're asking our families, do you feel like you have needs in that area? And if they say no, that's what we need to listen to as well.
Oh, we have fun questions.
Okay.
Okay, first one that came in is from Michelle Thomas Ross. She asks, how does education and socioeconomics seem to affect how a parent responds to you offering or doing the screening tool?
That's a very good question. I think data is still emerging, but on a lot of the open-ended questions, seeking to discover our patient's perspective and understand who and where they are, I think really helps to not put someone in a box, and it really honors whatever situation they are in. I had a young man recently that when I said, what do you want me to know about yourself in clinic? He said, actually, I want you to know I'm from Honduras, not Mexico. Everyone here keeps saying I'm Mexican. And I just thought, okay, if I hadn't asked this open-ended question, this was the first thing on this 10-year-old or 12-year-old's mind, and it was so important for me to hear and understand that. So I think those open-ended questions that are seeking to understand are really one of the best things we can do to bridge that gap.
And maybe one final question. We were getting asked, do you document the results in the chart, or how
We do. So we have, and I really, this is not my expertise. I let our social workers and mental health coordinator, our center director, Dr. Linneman, we have an epic flow sheet that clicks, and they're able to document what screening was done. It can pull it into notes, and we also talk about it in our preclinic huddles. But then we're also tracking the data over time as well.
Okay, thanks so much, Brandy. We appreciate it.
Thank you.
Okay. Next up, suspense. We have Susan Moore. I am reading off of my phone because we have fabulous presenters today, and every sentence of their bio deserves to be read. So, Susan Moore is a social worker from Cincinnati Children's. She is, a licensed independent social worker and has been part of the pediatric CF care team at Cincinnati Children's since 2013, which is very impressive in social work years. She completed her Bachelor of Arts at Bowling Green State University in 1996 and obtained her Master of Social Work from the University of Cincinnati in 2008. Prior to her position on the CF team, Susan was a child welfare social worker. So the ultimate social work unicorn right here. And she is going to be talking to us today about the standardized process for anxiety and depression screening with youth 8 to 11, which is very interesting given today's climate and CF care. So without further ado, Susan.
I first just want to thank David and Claire for inviting me to share our work. Just like Brandy, I am one small person on a very large team to do all this work. Our poster number is 500 for those of you that are interested. Wait a minute, sorry. There we go. It is touchy, isn't it? This one. There we go. Sorry about that. Like Claire said, I am Susan Moore. I am at Cincinnati Children's Hospital, and I have no relationships to disclose. To give a little background and why we thought this was important, many of you are familiar with the TIDE study. This really paved the way in the mental health screening process in our CF community, and really was the roadmap for screening our 12 and above patients. In fact, in 2016, the CF Foundation put in guidelines to screen patients 12 and above annually using the PHQ-9 for depression and the GAD-7 for anxiety. While the CF Foundation recommends screening patients 8 and above, it does not have formal guidelines or requirements. We believe that screening younger allows for early detection and really promotes the prevention of advanced needs as children age. And then also, as youth age and as younger children become eligible for CFTR modulars at a younger age, it's important to have screening in place to monitor this behavioral outcomes and provide for early and evidence-based support. So what we did was we first gathered our team. We're lucky enough to have 2 full-time social workers. We have a team psychologist, a program manager, a family partner, pulmonary attending, and a CF coordinator, center coordinator. We wrote a letter, and this is in no particular order of how we did things, but we wrote a letter to send out to parents explaining our process and why we thought it was important to change our screening to a younger age. Those letters were both emailed out, and we also discussed this process in a town hall meeting. Town hall meeting for us is a virtual meeting, kind of like a open forum to give information to families, usually through Zoom call or Teams meeting. And so we discussed this in that forum as well. We worked with our EPIC team at Cincinnati Children's. We're lucky enough to have EPIC. And we worked with the EPIC team to decide on the best screeners. Our project manager really took the lead in discussing with EPIC, and she would go and talk to the EPIC team and then bring back to the rest of the group the information from the EPIC team and share what could be built, what needed to be built, what already existed. So then we worked on triggers and firing rules to get this system to automatically trigger into our EPIC system. We decided on the patient outcome measurement system, which is a PROMIS screener for anxiety and depression. One of the benefits of having a child psychologist on our team is she's very familiar with screeners, so she had some background. We also had our asthma team was already using the PROMIS in some of their populations, so it was nice to be able to talk to colleagues about what was working well for them and what wasn't. These screeners actually came out of some work from the Health Institute, National Health Institute, and it was really designed to kind of build the communication between clinicians and patients in a clinical and research setting. We found these to be valid, reliable, and most importantly, publicly available. So we could find them, we had easy access to them. And then also the important thing for these screeners was that there was a parent caregiver proxy. So what that means is that the parent is answering on behalf of the child. So as you can see from some of these questions, they're answering, my child felt nervous, my child could not stop feeling sad. I have noticed in clinic, some parents enter the information completely independent without any feedback from the child, while others actually have a conversation with their child to discuss how they're feeling. Either way, the screener is completely valid. Like most screeners, there's lots of different versions. We decided on the 2.0 computer adaptive test, which is also known as the CAT. We mainly decided on this because it was already built into our EPIC system, and therefore it was really easy to use. We didn't have to wait for EPIC to build. What the computer adaptive test means is that the questions are randomly tailored to each individual. So based on the previous response, then the next question is automatically selected. It can ask anywhere from the minimum of 5 questions to a maximum of 13 questions. And it really produces the most accurate of scoring, reduces some of the fatigue that patients may have or caregivers may have in answering the same questions over and over. So T-scores are used. As a social worker, I can't begin to describe what a T-score is other than is the standard deviation from one side to the other. And the beauty of having a T-score is that it generally comes with a guide. And so the guide is found with the screeners. Again, they're very easily accessible. You'll see on this guide that there are 4 different kind of cut points. There's within normal limits, a mild range, a moderate range, and a severe range. When we're talking about screening our patients, we rescreen anytime a patient is between mild and severe, very similar to what we do in our 12 and aboves. If they're within normal, we would rescreen the next year. You'll see on this slide that it says between 330 days, and that just gives us some leeway because patients come every 3 months thereabout, and so if they come before or after their annual, we are still able to fire those rules to have them screened. So our process for this is the EPIC system. Actually, we wrote firing rules, like I said, and we put in the guidelines. We wanted them to fire between 8-year-olds and 4.5-year-olds. The visit type, we wanted it to be with cystic fibrosis patients that are coming back for follow-up care. We didn't want to screen them when they're coming in for a sick visit or a hospital follow-up. We just wanted this to kind of be a typical visit. We have 2 different locations, so we asked EPIC to screen at either location, and then we also added the criteria that the pass score had to be in there. So this is actually sent in EPIC, and parents will get it in their EPIC system through MyChart. They can answer ahead of time, which then would alert us that it is answered. If they don't go into their EPIC system or they don't go into MyChart prior, then the day of registration, the day of their clinic visit, they'll go to registration. They will be given a tablet that the screener is loaded onto. So again, the parent is completing on behalf of the child. If for some reason registration can get hectic, if for some reason it's not entered, either social worker or the child psychologist has the ability to enter that screener into the tablet ourselves manually. Once the screener is completed, EPIC will fire a message to us in the EPIC in basket, which tells us that the flow sheet has been completed. So we know that we need to review with the clients, with the patients. We then created a smart phrase that we use in our note that tracks what our interventions were and whether or not a parent completed or declined. We're also keeping track of the previous score and the severity category so that we know when to rescreen. So this is just kind of a snapshot of what this looks like in our flow sheet in EPIC. I apologize for those of you that don't use EPIC. I know this probably looks really different, but this just keeps track so that when we pull up our flow sheet, we know how many times the patient has been screened and when they haven't. You will notice on this particular patient, the anxiety screen was in the mild range, so they continued to screen each visit. The depression screen on the second screen bumped into the within normal limits range and therefore didn't need to be repeated, so was not on the last 2 clinic visits. Our smart phrase is embedded into the EPIC system. You'll see on the left is just kind of the skeleton of what our smart phrase looks like. And then once we plug it into our note, it becomes a much longer and detailed version. The advantage of using the smart phrase in the note is that it's comprehensive and it's organized. It can be used by either social work or psychology to have a uniform system so that we all know what we're looking at. Some of the cons is that it makes for a really long note, and it also prohibits us from doing some free text. So if we have a specific situation and we want to do free narrative, we would just have to include that in a separate section of our note. So results to date. Since November of 2022, when we did our first screen, we have screened 38 patients and parents of youth with children 8 to 11. The mean age was 10.2 and the median age was 10.1. We did 38 initial anxiety screens and 35 initial depression screens. Why it's different is probably, in my guess, is that the anxiety screener is first on the tablet and either the patient got interrupted or fatigue kicked in or a different provider came in the room and the tablet timed out. But there could be a number of different reasons. We had 25 rescreens based on our initial screens, so we knew we had to repeat 25 of those screens in the follow-up. So like I said, if the screeners range from mild to severe, we're going to do some intervention. So 92% of our youth were seen in clinic following screening by a member of the psychosocial team. Again, that could be social work, it could be our child psychologist. 37% of those received psychoeducation from a member of this psychosocial team. That Psychoeducation could be in the form of handouts, websites, just simply explaining what the screener is leads to conversation. We could hand out information about coping skills or just simply talk about some of the coping skills. 42% received in-clinic psychotherapy. So our psychologists actually went in the room during clinic and provided some immediate therapy at the time. And then 10 of our 38 youth were referred for follow-up with our child psychologist outside of clinic. Of those 10, all 10 followed up. 16 of our 38 youth, which is 42%, were rescreened for either both symptoms of anxiety and or depression. What did I do here? Sorry, it's so finicky. Here we go. So you'll see some of our follow-up changes. We are trending in a really good, reassuring position. A lot of our scores that are in the mild, moderate, and severe range are trending up to that green in the within normal range. You'll see that no one on a rescreen screened in the severe category or endorsed the severe depression score. So I think that this kind of shows moving towards the within normal range. It just really speaks to our early intervention, and that if we can get these kids screened at a young age and provide the interventions, that we can get them within normal range. We nearly doubled our kids in the normal range. And interestingly, this data also mirrors our 12 and above screeners that show that kids tend to have a more higher anxiety score than a depressive score. So some things to consider. All of you hopefully are screening your 12 and above. And so we think you also have opportunity to screen at a younger age. Nearly half of our youth screened were referred for psychological care follow-up. While the average scores were in normal range, there were some, that 17 to 24%, that had scores in the moderate to severe range. So that early identification and recommendations just leads to earlier intervention. Nearly half of our youth engaged in follow-up care after screening. Some of our limitations are just clinic limitations and time restrictions. Everybody's busy in clinic and trying to get in. Clinicians adhering to the SMART phrase, making sure we're all using it the same way and doing the same things accurately and categorizing things the same way. Our SMART list does not really allow for unique situations. So on those unique situations and times when we want to be really specific, we have to kind of play around with that. We did have a few parents that declined and were not interested. And then we have tweaked our SMART phrase. As we go along, we have learned that there were some things not included in our SMART phrase when we first started, and now they are included. We also did not include a breakdown of how many kids were screened in person versus telemedicine. Our child psychologist does a lot of virtual visits, telemedicine visits, and she is able to screen through that, but we did not analyze that data. Acknowledgements, like I said, we have a wonderful team, and they are all listed here. Jamie Miller is a fellow social worker, Liz Henty and Jesse Roach, Natalie Selker is our parent partner, Dr. Michelle Jelm, Matthew Wackler, and Dr. Stephanie Foligno. I'm sorry, tongue-tied there. These are our references. Questions?
Okay, you all are doing a great job submitting questions. Thanks so much. So we have two that I think I can combine, hopefully reasonably well. So the first question's thoughts about implementing the self-report versions for the kids for these questionnaires, and especially given potential discrepancies on internalizing symptoms from parent versus kid reports.
Yeah. So I think that really depends on your particular patient. You know, all kids are kind of maturing at different ages. Self-report, there are going to be some 8-year-olds that understand what you're asking and some 8-year-olds that don't. And I think that really is just going to be a patient by patient call. As far as parent report versus child report, yes, I do think that sometimes that can differ. And I think that can differ because sometimes the kids don't have the maturity to see some of the symptoms that they are expressing that parents see. And I think that at that age, it's still important to get some of the parent feedback.
So another question is related to mild, moderate, severe categories and whether those are linked to specific types of follow-up or clinic approaches.
Yeah, sure. So I think one of the things that I talk to a lot of our families about is that this is just a tool, and it is not a diagnosis, but it is just a way to have the conversation. And so some of those within normal range, they can still have some symptoms, and the mild can still have some symptoms. And it's just a matter of how much it's affecting their daily life and how interruptive it is. Certainly those that score in the more severe tend to have more interruption in their daily life. These behaviors tend to interfere, and they tend to cause more just disruption and affect, you know, their school and their household and their friends. So I think that those with a more severe tend to warrant a referral to Dr. Foligno quicker than some of those that are just in the mild.
Okay. Final question is about billing. So for the brief interventions that you were presenting that are used in clinic visits, are those billable? Do you all bill? Has that been successful?
So social work does not bill. Jamie Miller and I do not bill. So when we go in and we offer our services, which are generally just the resources, some brief intervention of just explaining the screeners, we do not bill. Dr. Foligno certainly does, and she will offer more intense psychotherapy. So that is billed.
Okay, thank you so much.
Okay. Next up, we have Dr. Carolyn Snell, who is the attending psychologist in the Department of Pulmonary Medicine at Boston Children's Hospital and an instructor in psychology in the Department of Psychiatry at Harvard Medical School. She obtained her PhD in clinical psychology from the University of Miami and completed internship at Stanford and her fellowship at Boston Children's. Her clinical work, research, and scholarship focuses on promoting adaptive coping in children and adults with chronic medical conditions and on evaluating and addressing patient, parent, and family stress in chronic illness populations. Dr. Snell has worked with Boston Children's Hospital Cystic Fibrosis program for the past 7 years and now serves as Director of Psychology for Pulmonary Medicine. Wow. So, without further ado, Dr. Snell.
Thank you. So I am really excited to be with you today and to share about our validation study for the CF stress questionnaire and new self-report measures for adults with CF that we've developed over the past several years. As you can see here, this is a really big team effort across multiple centers, so very fortunate to have worked with all of these folks on this. Just wanted to briefly state this project was funded by a pilot and feasibility award from the CF Foundation. And so just to tell the story of this a bit, so we began thinking about this project back in 2018, which was the final year of our mental health screening grant. We've been screening adults with CF like other centers had been with the PHQ-9 and GAD-7 and finding it useful in identifying a clinical population. But we also felt that the existing measures didn't totally capture some of the CF-specific issues that our patients were facing, which can also meaningfully impact their mental health. We were interested in developing a CF-specific measure that might identify a broader group of people, particularly in the context of some of the literature that we had reviewed, which showed that this could actually be a more powerful predictor of daily functioning. We used the framework of perceived stress to develop questions capturing both the stressors faced and individuals' responses to those stressors. So at last year's conference, we presented an update on our work here. So apologies to anyone who heard that if this is repetitive. But we were describing our pilot study and cognitive interviews. In brief, we started this project by adapting a well-established measure from the diabetes literature called the Diabetes Distress Scale. So we adapted that to CF and then gathered some feedback in pilot studies about some additional areas that it would be helpful to ask about. We then did some formal cognitive interviews and made further changes based on the feedback gathered. And so that's the process that led us up until today. And so what we're here to present today are the results of our multi-site validation study. So here you can see some of the subscale development and structure. So we had 4 subscales paralleling the DDS, the diabetes scale, and 3 new ones for cystic fibrosis, powerlessness, functional impairment, and economic burden, which the last seems particularly perhaps relevant in the modulator era. And so we did cognitive interviews, and after that, we added 3 items based on the feedback that we got. One regarding how PFTs can cause anxiety, one about the stress related to CF-related diabetes, and one about interpersonal factors. So as you can see this study, we had 200 adults with CF from 4 somewhat geographically diverse CF centers in Boston, Birmingham, and Buffalo. What I'm first going to be describing are some of the scale properties, including factor structure, internal consistency, and test-retest reliability, and then talk about convergent validity with other measures of health, quality of life, and mental health. And then finally, also explore some known group difference analyses that we did by mental health treatment history and higher versus lower FEV1. I will try to keep the energy up because it's a lot of numbers and statistics. So these are just our demographics. So our sample had a mean age of 32 with a large age range, most falling in the 20s and 30s. We had fairly even participation by men and women, some fewer men, as is often the case, and one non-binary participant. Our sample was, however, pretty heavily white and non-Hispanic. For our health variables, the average BMI was in the healthy range for people with CF, but it's worth noting that some were very high and some were very low. And we had a mean FEV1 of almost 80, so most people were falling in the mild to moderate lung disease range. We conducted a confirmatory factor analysis that supported the scale and factor structure. So here you can see the 7 factors representing our 7 subscales, and I have specific numbers at the end if people are interested in that. First, wanted to look at item scale correlations. So that's how well items hang together within a subscale. And I'll show that on the next slide. We next looked at internal consistency with Cronbach's alpha for each subscale as a whole. All of the subscales, fortunately, we found met the internal consistency cutoff that is often used of 0.7. We did have, as I note here, a couple of difficulties with floor effects with the provider-related stress scale. Thank goodness most people did not report a lot of distress related to not feeling understood or heard by their provider and things like that. But what we heard in our cognitive interviews was that people felt that that was a really important area to ask about if those issues are present. And so we did keep it in the questionnaire, but you'll see for that scale, the statistics look a little different. Finally, we did have good to excellent test-retest reliability. So I'll show you some of the numbers for these. So this is our internal consistency data with the item scale correlations. So you can see starred down the diagonal which items are on which subscale. And then the highlighting is just supposed to help visualize kind of the degree of correlation with the understanding that these are ranges with, and artificial cut points to some extent, right? But you can see that we have moderate correlations, which we would want for most items with their corresponding subscale, a little bit lower for provider-related distress, as we were just talking about, and higher for functional impairment in the lower right. Those questions were all about my CF gets in the way, or my CF treatment gets in the way of different life domains, work, personal life. And so what I think is happening is that if CF interferes with one life domain, it tends to interfere with many of them, and that's why those items hang together so strongly. Here are our retest reliability data. So here, these are for a subset of 45 participants who took the measure again 2 weeks later. And you can see we have mostly good to excellent reliability, interpersonal, just missing that, the mark, but pretty close for all of the subscales. So moving on from internal consistency and retest reliability to convergent validity. So again, to summarize on words, what you're going to see in the next slide, since this is a little difficult to visually represent, we had strong correlations with our mental health outcomes, i.e. PHQ-9 and GAD-7. We had moderate correlations with some of the CFQR subscales, but lower with others. And we had lower correlations for some of the health variables. So I'll show you some of the specifics of that. So here you can see the PHQ-9 and GAD-7 columns mostly in blue, showing strong correlations with mental health outcomes. We also saw some moderate correlations with the CFQR social and treatment burden subscales, but lower for the other CFQR subscales, pardon me. We also looked at secondary outcomes at the trust in physician scale and at treatment complexity. And if folks have questions about those, I'm happy to answer. Those weren't as highly correlated either. And we saw less correlation with health itself. So suggesting that maybe the type of stress that we're measuring has a lot to do with, more to do with appraisal than perhaps some of the concrete facts of people's CF, but something to explore further. And then finally, for some of our exploratory outcomes, so we looked at known group difference analyses, and as we expected, these were reassuring. We saw that people who had a history of mental health treatment and people who had lower FEV1 scores had higher scores on the stress questionnaire, meaning they're experiencing more stress. Here are some of those data from mental health treatment history. So we asked people if they had ever been or currently were in therapy. We also asked if they had ever been or currently were on medication, because those were easier things to ask about than trying to ask people if they've been diagnosed with something which they might not know. I just included one of these tables here because they were all pretty similar. But you can see that those who had a mental health treatment history had more distress across the board on the CFSQ. And I also just wanted to point out, I think it's noteworthy that over 60% report having been in therapy at some point, which I think seems pretty good. And then we have our second known group difference analysis with FEV1, also showing more distress for those with more severe lung disease, where starred values indicate statistically significant differences, so for some of those scales and not all. And this provides some reassurance to me with respect to convergent validity with the health variables, that at least we're finding that there is this relationship with lung disease, lower versus higher, and that maybe what we're seeing in terms of the other correlations may have to do with the fact that many people were falling in the mild range, but again, something to investigate further. So in conclusion, we feel that these results suggest that the CFSQ is a valid and reliable measure in terms of its internal consistency, its retest reliability, and convergent validity with measures of mental health and quality of life. We note that the CFSQ is more highly correlated with measures of mental health than with health outcomes. And we showed that exploratory analyses revealed that those with a history of mental health treatment and those with lower FEV1 scored higher on the CFSQ. So further directions for this, we want to disseminate it, of course, for clinical and research use. I had hoped to just have a QR code that people could scan, but I want to offer it to anyone in the CF field who is interested in using it. So please just contact me. It is poster 295. And one way in which we're planning to use it, which I'll share with you, is we want to use it as both an assessment and an outcome measure for a group that we're developing with people with CF who have anxiety and or depression. So to be able to look at what are the biggest areas of perceived stress in your life that are specific to CF, and then really see if we can move the needle on some of those things with the group itself that's focused on CF-specific stressors. That would be exciting in terms of being able to show change. Finally, just wanted to thank our incredible statisticians who did so much of the work underlying this, our methodological consultants, Beth Smith and Adrienne Alpern, our collaborators in Birmingham and Buffalo who've been amazing, and our supportive center directors. You can see this is the work of a large team.
Okay, so I can get us started. If other people have questions, please go ahead and submit those in the on the app. So, Carolyn, I was interested in, I think you got the same question last year, in terms of extending this to pediatric samples or thinking about how things might differ, also on the caregiver front. So any thoughts about that work, or is that work sort of being developed on your side?
Not yet, but I would certainly be interested in doing that at minimum for adolescents, but even potentially for younger ages. I mean, I think that would probably require more extensive, interviews and developing things a little more from scratch for younger kiddos. But no, I think that this could be a great measure to use to, perhaps in a similar or even the same format for 14 and above. We would just have to see if it was valid for that age group.
We had a question from the audience, just asking some more specifics about the CFSQ, if there's questions about spirituality, existentialism, and identity.
Good questions. So not specifically spirituality and identity. However, I did want to, share if folks are interested some sample items so you get an idea of the measure and some of the things that we're asking about. So here are some sample items for each one. You'll see that many of them have to do with feeling overwhelmed about a particular area, feeling that you don't do things well enough in a certain area, things like that. So just to give a flavor for kind of some of the questions that we're asking here.
I'll be loud. I saw on your slides that there were 12 surveys that were excluded because they weren't filled out completely.
Mm-hmm.
I am personally scarred by that happening in a study I did. So do you have any ideas about how you might catch or do things differently so you can get those 12? Because that makes a big difference.
True, and I think we actually had a really effective and fantastic research assistant who both camped out outside, in the hallway to catch people in clinic visits, and was just really effective at presenting the study. And so I think that's the reason that it's not much higher than 12, right? But I think that the biggest things that happened were people either had to leave clinic or that something else, they urgently needed to meet with somebody else and then weren't able to come back and complete it afterwards.
And I think, Carolyn, maybe just a last question. So in the context of ETI and modulators, I'm just sort of, maybe just a thought question. Do you see the questionnaire was developed sort of in the context of those coming into play? And so do you think some of these questions will need to be modified in terms of perceived stress? Did you have conversations about that when people are filling out questionnaires about effective modulators on perceived stress? I've seen it, of course, in literature go both ways. Mm-hmm. So just any thoughts on that context?
Yeah, so we did a separate study on modulators and mental health, looking at some of this. But we really developed this in the midst of that transition, right? And so when we started, people were just starting to get on Trikafta and in clinical trials. And then when we did our cognitive interviews, most of the people that we were doing it with had recently started Trikafta. And so we do feel that we incorporated some of that input. With that said, it's an ever-evolving landscape. And I think, of course, it'll be worth revisiting this along the way. And actually, I think, some of the subscales that we developed, like the economic burden, I feel like are perhaps particularly relevant in the era of UTI. So we're happy that that's there.
Okay, thanks so much, Carol. Just a quick note for people. I see that there's some folks sitting in the back, which is totally fine if that's your preference. We do have seats up front if you're interested. No pressure, but just to let you know.
It's fun up here. Okay. Next up, we have Dr. Deborah Friedman, who is a licensed clinical psychologist in the Massachusetts General Hospital, MGH, Department of Psychiatry, the mental health coordinator for the MGH Pediatric and Adult CF programs, and assistant professor of psychology at Harvard Medical School. Dr. Friedman joined the faculty at MGH in 2007 after completing a 2-year NIMH-funded clinical research fellowship in pediatric health psychology at Warren Alpert Medical School of Brown University. She is also the co-founder and director of the MGH Pediatric Behavioral Medicine Program, providing clinical research and training activities focused on improving pediatric health, resilience, and coping with acute and chronic illnesses in children, adolescents, and their families. She also provides direct outpatient care to youth and families in the Child and Adolescent Psychiatry Outpatient Clinic and to youth and adults with CF as a member of the MGH CF program's interdisciplinary team for over 10 years. Dr. Friedman's research, which has been funded by the CF Foundation and Vertex Pharmaceuticals, focuses on developing mental health and palliative care interventions that can be integrated into CF care. With input from key stakeholders, she has authored a CF-specific CBT intervention for the prevention of depression and anxiety for adults coping with CF, also known as CF-CBT. Everyone should look it up. It's great. And co-leads a multi-center randomized controlled trial of this intervention. A blended care, internet-delivered model for adults, also known as eHealth CF-CBT, has been developed in English and Dutch that is currently piloting in the Netherlands. With additional stakeholder input from adolescents with CF and caregivers, Dr. Friedman has also authored a version of CF-CBT that is developmentally targeted for adolescents with CF, with resources for caregivers, CF-CBT-A, and a multi-center pilot study is underway. Yay! She also co-leads a CFF-funded trial to develop and pilot a psychosocial pain management intervention for adults with CF. Also, Dr. Friedman serves on the editorial board of the Journal of Pediatric Psychology. Look out. Without further ado, Dr. Friedman.
Thank you so much. Thank you for inviting me and to be part of this amazing panel today. I also want to acknowledge this is the work of an incredible team. I'm going to elaborate on that more as we go. I will see this. Oh, yeah, thanks. There we go. These are my, too fast. Those are my disclosures really quickly. How do I go back? Oh, there we go. Okay. Sorry. So CF-CBT was developed in response to the need for preventive evidence-based mental health interventions that are tailored to the needs of people with CF. It's an 8-session CBT-based program for adults. It was developed in partnership with the CF community and specifically tailored to address the emotional challenges of living with CF. There were a lot of ways that we, as a team, developed this program to be specific to for people with CF, including examples throughout that were provided by the CF community, who also contributed to this program, and as well as direct quotes from people with CF throughout the materials. The program content emphasizes the interplay between physical and emotional health and addresses barriers to sustaining CF daily care while keeping a focus on also acceptance, self-compassion, and building on existing strengths and resilience. One major goal of this project was to reduce barriers to access to mental health care. And for that reason, CF-CBT was designed to be integrated into primary CF care through delivery by CF care team members. It was also designed to be flexibly delivered either in person or by telehealth, and also able to be delivered outpatient or during inpatient admission. During the RCT, actually, we started with the visits. The first visit was supposed to be in person, and after that, there was a choice between being in person or by telephone. And then we had to quickly shift as the pandemic started, the very beginning of the RCT, and so really the majority of the sessions were delivered by telehealth. Following a pilot study showing feasibility, acceptability, and promising effectiveness, our team conducted a multi-center, randomized, waitlist controlled trial of CF-CBT in 60 adults with CF. Adults scoring in the mild range on measures of depression or anxiety or both were eligible to enroll. And eligibility criteria was meant to be pragmatic and inclusive so that participants were included who had a history of more severe depression or anxiety that was currently at the baseline in the mild range. And those participating in co-occurring treatments were also eligible to enroll, with the exception of participating in another CBT. The CF-CBT program was delivered by multidisciplinary CF care team members at 4 sites, including Mass General Hospital, Buffalo, Stanford, and the University of Kansas Medical Center. And study clinicians participated in an 8-hour training and ongoing consultation. And our team included social workers, a nurse clinical research coordinator, psychologists, a psychiatrist, and a pulmonologist. "60 participants enrolled in the RCT and received a baseline assessment, and then they were, after that, randomized to one of 2 groups. So one group was the immediate intervention, or IT group here, and that group was offered the 8 sessions of CF-CBT immediately following their baseline assessment. The other group was the waitlist control group, and that group was offered CF-CBT following a 3-month waitlist period, during which time they received treatment as usual. Outcome measures were completed at baseline, again after 3 months, and pre-CF-CBT for the waitlist group, and then for both groups immediately post completion of CF-CBT, and again at 3 months and 6 months following completion. So today I'm going to be talking about the primary results of the RCT, and the longitudinal analysis is ongoing. Statistical analyses compared mean change from baseline to 3 months for the immediate treatment versus waitlist control groups, with the outcomes of depression and anxiety symptoms, perceived stress, coping self-efficacy, and quality of life. And following those main analyses, we also completed a secondary set of analyses in which we pooled both of the groups receiving treatment to estimate pre-post CF-CBT changes in those outcomes. Because the study aimed to examine the use of CF-CBT preventively to prevent escalation of symptoms from the mild range, we excluded 7 people who were in the waitlist control group whose PHQ-9 and GAD-7 had increased above the mild range while on waitlist. They were removed from these secondary analyses in order to take a more conservative approach and maintain equivalency between the groups. So this is just an illustration of the model. So the main analyses compared the 2 groups over that first 3-month period, and the secondary analysis pooled the 2 groups receiving treatment. So participants had an average age of 33 years. They ranged from 19 years to 63 years. Mostly female, identified as female, and mostly white. 2 individuals self-identified as Hispanic or Latinx. FEV1 ranged from 16 to 124, with a mean of 69. 12 people met criteria for advanced disease, and 5 were post-transplant. And as you can see, most worked at least part-time and were highly educated. In addition, most reported having some kind of previous mental health treatment, but no experience with CBT. Only 25% of the sample had never taken medication for depression or anxiety, which suggests that for many, their mild PHQ-9 and GAD-7 scores at baseline could reflect, a partial remission from a more significant, moderate, or severe episode of depression or anxiety, rather than a first episode. So I'll start in talking about the results by talking about the feasibility and acceptability data. So our results strongly confirmed what we saw in the pilot regarding the feasibility and acceptability of CF-CBT. 55 of the 60 participants, so almost all, completed all 8 sessions, and the program was very highly rated. So we looked at a validated measure of treatment satisfaction called the Client Satisfaction Questionnaire, and there was a median score of 31 on that scale that ranged from 8 to 32. With regard to the main set of analyses, we saw a trend to greater improvement in depressive symptoms on the PHQ-9 in the immediate treatment group when compared to the control group, while the difference in mean change in anxiety symptoms was not significant. Next, we examined the outcome of coping self-efficacy. So I'm going to talk a little bit about that. Coping self-efficacy, which is the confidence in one's ability to cope with stress, and particularly with the challenges of living with CF, was measured by the CF Coping Self-Efficacy Scale, which was developed by our team with input from participants in the CF-CBT pilot study. And that did have demonstrated preliminary evidence in this data set of scale reliability and construct validity. And CFCSE, CF Coping Self-Efficacy Scale, consists of 5 subscales, 21 items, and it assesses confidence in being able to use coping skills which are targeted by the CF-CBT program, including those specific to coping with CF. Items are rated on a 10-point scale from 10 to 100, from very uncertain to very certain in being able to use these particular skills. And we thought it was important to look specifically at coping self-efficacy as an outcome because it's been identified as a critical component of successful outcomes for CBT interventions. It's a mediator of change, both for immediate and long-term anxiety and depressive symptoms. And in chronic illness populations, it's associated with improved quality of life and positive health outcomes. Positive health outcomes, including pain, fatigue, and decreased disease-related distress. So as you can see, there was significantly greater improvement in CF coping self-efficacy in all 5 subscales in the immediate treatment group when compared to the control group. So in summary, when comparing the immediate treatment to waitlist control group, we did see a trend toward improvement in depression symptoms, a significant improvement in coping self-efficacy, with no difference between the groups for change in anxiety, perceived stress, or quality of life. In the secondary analysis then, in which we looked at both groups combined, pre and post CBT, there was a trend toward improvement in both depressive symptoms and also this time in anxiety symptoms. There was also significant improvement again in all 5 coping self-efficacy domains, and in addition, a significant change in perceived stress, and with 7 of the 12 quality of life domains on the CFQR. Let's see, that's a secondary analysis results. In conclusion, the results of this RCT confirm the feasibility and acceptability of CF-CBT and supports the potential for CF-CBT to improve outcomes, particularly coping self-efficacy, also perceived stress and quality of life, and to prevent escalation of depression and anxiety symptoms for adults with CF. And we wanted to mention it's notable that 7 of the 27 participants in the waitlist control group had PHQ-9 and GAD-7 scores that progressed into the moderate or severe range during that waitlist period. So that just does suggest a need for closer monitoring, early intervention for those with anxiety and depression scores in the mild range. And we're very excited now to be beginning a dissemination and implementation phase for CF-CBT across CF centers in the US and Canada. We're conducting a trial now supported by the CF Foundation to examine best practices to optimize implementation and reach of evidence-based mental health interventions for people with CF, across CF centers serving diverse populations. And we wanted to note our next training will be a live virtual training. It'll be February 7th. So please, it's a full day, so please save the date if you're interested. There is a QR code here that will take you to a link if you want to indicate your interest in receiving more information. And you can also feel free to contact myself or Anna Georgiopoulos directly with any questions that you might have. And Dr. Georgiopoulos will also be presenting some initial data from the implementation trial tomorrow at 9:30. We also have several exciting adaptations of CF-CBT. As mentioned, our adolescent program is currently piloting at 3 centers. Our eHealth program, led by Marika Verklee, is being implemented at CF centers in the Netherlands. And we have a virtual group format of the adult CF-CBT that will be piloted in Canada. And lastly, I really want to take time to acknowledge the incredible teamwork that makes this possible. In particular, thank my co-PI, Dr. Georgiopoulos, the CF-CBT site PIs, clinicians, statisticians, our project manager, and research coordinators for all the incredible contribution to this project. And most importantly, thank you to the many members of the CF community who have contributed to this work and participated in the clinical trials.
Okay, we got several questions from the audience. So the first one was just in regards to recruiting and sample demographics. The question is, can you comment on likely barriers to recruiting a more diverse sample in terms of race, ethnicity, and education?
Yeah, that's such a great question. I mean, I think there may have been some barriers in terms of just the demographics of the centers, and we're really hoping that that will, that the diversity will be much more expanded as we implement across a wider range of centers. But there's also the barriers that I think, come up in any clinical trials and mental health interventions. So we're also, hoping to look more at that in our implementation trial, to look at barriers and facilitators to reach of mental health and evidence-based mental health interventions across different populations. And we have recently translated the CF-CBT program into Spanish, so we're going to be able to distribute that as well and hopefully reach more people in that way.
Personally, I was just curious. I mean, the feasibility data was outstanding. So just curious about how you all were so successful in retaining your participants. I think it was like 95% completed all 8 sessions or something like that. So any comments on the magic there?
I wish I could say, and I think it shows that this is something that people really feel was helpful to them and that they really felt supported. And and having something that was very specific to CF, and also provided by their medical team. Often by people spoke a lot about how important that was to have someone who understood CF, who they were comfortable with, that it provided this more focused approach to care. I think all of that really contributed.
We got an interesting question about, do you all have any concern of, quote, over-treating, unquote, people who are scoring in the mild range, which is easy to do, especially when there's somatic symptoms of depression in the context of CF. So any thoughts on that in terms of a prevention trial and what that might mean?
Yeah, that's really interesting. I think one of the things that we really wanted to do was not to really normalize the stress that goes along with living with CF, even if and not to pathologize. The people who were in the trial, were there because they wanted to be, that they felt that this was going to be helpful to them. So yeah, I think, there's, could be error either way, Yeah.
There's a lot of people who, this mic's a little funky. There's a lot of people who are interested in both the self-efficacy questionnaire, wanting to know if that's available for use, and sorry if I missed that, and also just to clarify that the training for CFCBT, is it freely available? How is that sort of disseminated?
Yeah. Yes. So the CF coping self-efficacy scale, we're working on the publication. We hope to have that available, but the scale itself is available. Feel free to contact me if you're interested in using it. And the training is, yes, it's going to be free. It's virtual, and we also intend to have CE credits associated with that.
Okay, thanks so much, Deborah. Appreciate it.
Okay, and for our last presenter, we have Dr. C. Virginia O'Hare. Oh, man. Okay. Do you have... Okay. O'Hare is a licensed clinical psychologist. She is a clinical professor at Thomas Jefferson University Hospital's Department of Psychiatry and Human Behavior, and serves as the director of Jefferson Sitter City Clinic for Behavioral Medicine. She has undergone extensive training in acceptance and commitment therapy, ACT, and is dialectical behavior therapy, DBT, certified. Her research and clinical work involves the application of acceptance-based behavioral therapies to healthcare providers and to patients with chronic illness. She obtained her PhD in clinical psychology at Duke University, and she served on faculty at Duke University Medical Center for 5 years as a transplant psychologist, working closely with patients awaiting and recovering from lung transplantation. She has also co-authored 3 treatment manuals: ACT with CF, ACT with CF Adolescents and Families, and ACT HIV. Dr. O'Hare and her family moved to Philadelphia in 2012. She now lives in Bryn Mawr, Pennsylvania, with her husband, 2 kids, and 2 rescue mutts, importantly named Sandbox and Dogbert. Without further ado, Dr. O'Hare.
Thank you. Hi. So I succeeded in my first mission of not falling off the stage, which was a high priority. All right. I'm delighted to chat with you about the preliminary findings, longitudinal findings yet to come, of our ACT with CF randomized control trial. Is it this? No. Is it this? No. Oh, it's that? Oh, come on. Okay. Oh, no. Perfect. Thank you. So this whole project was generously supported by the Boomer Esiason Foundation. Thank you. And the CF Foundation gave support for me to come and speak today in the form of reduced registration fee. Thank you. So here's our team, many of whom are here today. We've got our biostatistician, Patrick Smith, the Augusta site rep, Chris Drescher, Heather Brushwine from UVA, Krista Engel, Duke site rep, and Chelsea Nurse, our research coordinator. Hallie Kushner was our fidelity coder, not here. And we have a CF patient representative, Katie Lawless, and then our medical liaisons, Michael Stephen and Jeff Ho. And then our study clinicians were master's level psychology students under my supervision. So they underwent a one-day training in the ACT protocol and a training in the supportive psychotherapy protocol, and then we met for supervision weekly. Did I get it? No, shit. There, yes, okay, all right. So just to recap, this developed from our pilot study, active CF pilot study. We had 30 CF patients, adults, with elevated scores on the GAD-7 and or PHQ-9. This was maybe it was 2016 to 2018, somewhere in there. And we gave patients the choice of, do you want to get this over telehealth, which at the time was WebEx, with video on, or do you want to come in person? And 24 chose webcam. And interestingly, so at the time, we couldn't bill for webcam sessions, right? This is back in the pre-COVID days. So all of the webcam sessions were provided by my students because they couldn't bill. And then all of the in-person sessions were provided by me, and I billed patients' insurance. No differences were found between the two. So this shows that this protocol was something that we were well able to teach master's level clinicians, and that nothing was lost via telehealth. Everyone wanted to continue. One person dropped out only after the 30, out of the 30, and that was due to pregnancy, and then she re-finished after the trial had ended. And here were our results from the pilot. Symptoms of anxiety reduced across the 6 sessions and then rebounded at a 3-month later follow-up. Depressive symptoms stayed reduced, although rebounded just a little bit. Cognitive fusion reduced and stayed down. Now let me take a moment to tell you about cognitive fusion. So this is rigid attachment to thoughts as truth. And keep this in your brain because it may be important later, spoiler alert. So for example, if you have the thought, why bother taking all my meds? It's impossible to have perfect adherence. That's the type of thought that might get in the way of carving out enough time to do treatments prior to a social event or similar. Or what if you have the thought, what does it matter? I'm going to die young anyway. Or what if you have the thought, I'm always going to feel anxious no matter what I do? So fusion is rigidly attaching to these thoughts as like capital T truth. And the change in cognitive fusion that we were able to affect remained after 3 months of no treatment follow-up. Then also, interestingly, we got this pretty cool finding that lung function measured by FEV1 FVC ratio actually improved over 3 months. We don't know why. So this is all from the pilot. Correlation does not imply causation. It's not that the pilot necessarily made people's lung function better, or did it? So why? Did they improve treatment adherence? Did they get more physically active? Was it that following their values, what they wanted to be about, changed things in some way? So this is what we really wanted to look at with this randomized control trial. Does ACT work better than just talking with someone? So that led us to this multi-site randomized control trial. So before I get into details, let me just tell you in a nutshell, if you haven't attended one of the many, many talks that have been given at this conference over the years about ACT. ACT is all about improving psychological flexibility, getting flexible. ACT's all about what do you want to stand for in life, and how can you take a step towards that right now? Don't wait till all of your ducks are in a row. Right now is the time to take a step. So, we'll hear people saying, when my symptoms are under control, that's when I might start thinking about dating. So ACT would say, well, why don't you make a profile right now? Or why don't you look at some, online dating sites and just kind of see what's out there? Take a step towards it right now. Don't wait till everything's perfect. And then supportive psychotherapy was more of like an insight-oriented treatment where the therapists could ask any question where the goal was getting to know the patient's experience better, and the therapist could provide kind of warm, fuzzy, good validation, but couldn't give any direct coping skills. So we had 124 adults with CF with elevated PHQ-9 or GAD-7 score. We had a very diverse patient population from centers all across the U.S. So we had Philly hospitals, Duke, UVA, Augusta, Columbia, Oregon, bunch of others. And everyone got 6 weeks of telehealth delivered ACT with CF or supportive psychotherapy. So they were randomized like by a flip of a coin. 61 got ACT, 63 got supportive. We did pre-post assessment and then 3-month follow-up. We're also every session was Fidelity coded and a subsample, a fairly high subsample, like 75% was double coded. We're also piloting a new measure, CF mental health and wellness measure. And this is at poster number 462 if you want to learn more about it. And then this big study is at poster 464 if you want to check that out too. All right, moving on. So out of 146 screened, 124 were eligible. So the others didn't meet inclusion criteria, so they didn't have a high enough score on GAD-7 or PHQ-9. 8 never started treatment. 27 dropped out. No significant difference between ACT and supportive. Dropouts were twice more likely to be partnered versus single, with lower family income, more depressed, and with lower psychological acceptance. Participants had a mean age of 34, 70% were female, 95% Caucasian, and about half were partnered. Most were on a modulator, 67%, and about 60% were on a psych med. At baseline, folks were mildly depressed on the BDI and mildly anxious on the Beck Anxiety Inventory, and highly over-controlled, so using predominantly over-controlled coping styles versus under-controlled. So over-controlled is like kind of rigid rule following, being stoic in the face of stressors, masking emotions, continuing to use one strategy even if it's proved ineffective. So most participants attended all 6 sessions. So the median for those who attended 1 session was 6. ACT folks attended a significantly greater mean number of sessions than supportive. So all but 2 ACT participants attended 5 or more sessions, whereas in supportive, dropouts occurred all throughout. 2 independent raters coded 102 sessions, and fidelity to the treatment protocol was high, 92%. And the Gestalt quality ratings were also high, or 94%. So are you doing supportive if you're in the supportive condition? Are you doing ACT if you're in the ACT condition? So both ACT and supportive demonstrated improvements in psychological functioning over time. So that's great. Everything kind of works. However, greater improvements were found in the ACT condition. Psychological functioning was improved to a greater degree in ACT. And the largest improvements in psychological functioning were due to change in cognitive fusion. Remember, we talked about that rigid attachment to thoughts as truth. So we can kind of unstick from those thoughts, allow those thoughts to happen, and due to changes in acceptance and committed action. Both groups experienced reductions in depression, and there was a trend for ACT improving BDI score more than supportive did. And then both groups had kind of modest reductions in anxiety. Greater increases in psychological flexibility were associated with greater reductions in negative affect. So the more flexible you get, the less miserable you're feeling. Baseline negative affect, baseline psychological flexibility, and changes in psychological flexibility were the strongest predictors of treatment-related reductions in negative affect. Folks in ACT with greater self-reported baseline barriers to medication adherence reported greater reduction in barriers after treatment. So specifically, and you see this in the far right, ACT's red, supportive is blue. Those in the highest tertile of baseline barriers to adherence showed greater reductions in the ACT group versus in supportive. And reductions in cognitive fusion was a thing that was associated with reduced barriers to treatment adherence. So if you can defuse, if you can detach, unstick from those kind of doom and gloom radio station thoughts that we all have, then treatment adherence improves. Reductions in symptoms of depression, anxiety, and acceptance did not impact barriers to adherence. And then we looked at changes in the FEV1-FVC ratio from pre to post treatment as a marker of pulmonary health. And while there was no evidence suggesting consistent group improvements, You can see that post-treatment ratios in ACT were slightly higher than in supportive. However, individuals, again, if you look at the far right, with lower baseline FEV1 FVC ratios, sicker patients, demonstrated greater improvement in ACT versus supportive. And this is only a trend, but look, we got 0.076, so close. So, in conclusion, telehealth delivered ACT with cystic fibrosis, ACT with CF, was superior to supportive psychotherapy in improving psychological functioning, particularly for those with greater medical burden. The greater the medical burden, the more ACT with CF proved beneficial. Also, the more psychological flexibility folks had at baseline, the more improvement people demonstrated in ACT with CF. Cognitive fusion, acceptance, and committed action all improved in ACT, which is consistent with the mechanism of action of ACT. This is ACT doing what it's supposed to be doing, getting people more flexible, defusing from problematic thoughts. And greater increases in psychological flexibility were associated with greater reductions in negative affect. Folks found the ACT with CF protocol was engaging, enjoyable, most completed all 6 sessions, versus in supportive where there were dropouts throughout. And ACT with CF reduced self-reported barriers to treatment adherence, particularly among those with greater self-reported barriers to adherence at baseline. So taken together, findings suggest that ACT with CF is an effective and enjoyable talk therapy for adults with CF, particularly those who are sicker. And those with more psychological flexibility at baseline may enjoy maximum benefit from ACT. Folks with poorer treatment adherence may also experience an improvement in adherence with ACT with CF. So one of the things we're suggesting is assessment of psychological flexibility could be a really good tool at baseline to figure out who might benefit from ACT. So it's great that there are a bunch of different treatments that sounds like really do help improve mood and mental health for folks with CF. So not only today have we heard of a bunch of awesome screening tools, but we've also heard about this CF-CBT. So then trying to figure out, how can we give patients best choice of choice of treatments is always great. We don't want just one thing. So psychological flexibility might be one of those things that if you're already kind of high in that, you might be more likely to benefit from ACT. And then I think it's still interesting to investigate the mechanism by which ACT with CF improved barriers to medication adherence and improved lung function among those with more barriers and worse lung function. And then adaptation of the ACT with CF protocol to families, trying to reach adolescents and children with CF and their family systems. That's really our next step. And then expansion of this protocol to other rare diseases to improve mental health, and overall treatment outcomes. And we've actually already got several studies in the pipeline underway for that. So really wanted to give a warm thanks to all of our CF participants, and if possible, an even warmer thanks and infinite appreciation to all of you, many of whom are sitting in this audience, who responded to the countless nagging emails from me and from Chelsea and the rest of my team and sent us a bunch of patient data in the middle of a pandemic. Thank you. Heartfelt shout out to Chelsea Nurse, who served as our research coordinator, not only in the pilot, but throughout the whole randomized controlled trial. Having this continuity of leadership on our team is just fantastic. And then far beyond financial support, the grace, we got a whole year extension on this project due to COVID, camaraderie and passion shared by the awesome entities at the Boomer Esiason Foundation just made this whole project possible. And they have a booth for the first time ever. So go check it out. If, among many other glories of this booth, you can see an awesome picture of Boomer's grandson, Casper. All right, thank you.
Okay, so a couple questions here. First one, is it possible that reduced cognitive fusion changed what people perceived as an adherence barrier rather than actually changing the amount of treatments people did? Was actual adherence behavior measured?
Yeah, that's a great question. That's been something that's kind of been percolating on my mind also. So I don't know that cognitive fusion would change people's perception of the barriers. This is more things like, I don't fill my prescriptions, and it's hard for me to imagine that defusion from perfect prescription filling might allow people to say, I guess I do, even if I don't. So I don't know. I like the sentiment of that question. No, we did not have a direct measure of adherence, and that's definitely something I think could be useful in the future. Part of our obstacle was we're running this study during COVID, and getting the sort of monitoring that would be necessary to really do a deep dive into adherence just didn't seem feasible at the time. That said, I love that as a future direction.
So the next question is, would there ever be a situation where you would assess that a patient's identified next step to just go ahead with was actually not appropriate for their current mental health state? And if so, how would you advise them in an ACT frame?
Okay, I've spaced. Sorry. Say again.
That's okay. So you know how you were talking about how it's sort of the next step, the values driven. So
Oh,
has there ever,
yeah,
if
okay.
it's contraindicated. I guess.
Okay, no, I see what you're saying. So it's rare that I get into micromanaging what the step is. It's more like with ACT, we try to figure out what's your value. So your value could be have a relationship filled with love and affection. I guess the patient could say, so my next step is to have unprotected sex with as many people as possible. And I'd be like, oh, hell no, that's not happening. Come on, you're immunocompromised. Like, let's think about this. So I would exercise, good sort of human and clinical judgment. But ACT is more about helping people to figure out what their values are. And then the committed action part is taking a step in the service of your values. Usually people are pretty good at coming up with those steps.
Okay, maybe two more questions, and then we have some for the panel coming in, which we would love. I think we're going to have a little bit of time at the end, so if you have thoughts from the group, please go ahead and submit those. Do you have any resources for patients who found the therapy helpful and would like to continue with you or your staff? And there's some questions about, people want training in this, is that freely available? How is that going to roll out?
Yeah, thank you. I love all those questions. So the way that we did it for this study is that no, patients were not able to stay on with us, which is a difference from the pilot. So in the pilot, people could stay on if they wanted to, and everybody did choose to stay on. In this case, just in the interest of we wanted to reach as many people as possible, we wanted to provide a short intervention for the context of the study. We didn't allow people the option of staying on. That said, if people were real passionate about ACT, we would help them find an ACT therapist, but mostly using their CF Center's resources and the Psychology Today website, searching in particular for folks who provide ACT. And yes, the hope is to do an ACT training yet again. That could be awesome.
Okay, perfect. I think what we'll do is we'll transition, thanks Jenny, to panel questions. Big round of applause. So one of the questions for the group is the foundation's recommended more services for families with CF. Has anyone on the panel adapted their mental health screeners, measures, interventions for siblings without CF who also, though, experience CF-related distress?
Okay, sorry, I know I've already talked a lot, but I'm going again. Yes, we have our ACT with CF protocol is adapted for teens, including for siblings with or without CF. We have a whole sibling circle component, which is mostly the brainchild of Chris Drescher, who's sitting here in the audience. And we're looking forward to rolling that out as soon as we get funding.
And I had sort of a question between sort of ACT and CBT, not to pit them against one another, but I will. So a question I get a lot of the time in supervision in my role as a clinical supervisor of my grad program is, how do I pick? Because they are different theoretically. They have some different components. They're interrelated in some aspects. But I was just curious to ask both of you, since you're here, in the context of CF or just general clinical practice, when we're faced with how should we direct someone to an intervention, one, it's going to be practicality about what's available, of course, but let's say that there are equal avenues for clinical intervention. Do you have sense of like how we can best make those decisions or talk with our patients about what might be the best fit for them?
So I would say, at least, from my perspective with CF-CBT, I think it does incorporate a lot of ACT concepts and techniques, and so I don't think it's like as black and white of like one or the other. But I do think, like maybe you were saying like about flexibility, that could be a factor, maybe pointing someone more towards towards ACT, but you could also kind of, I wonder if someone could be kind of shown both of the manuals and see like what really speaks to them, what's interesting to them. Yeah.
I love that idea. Letting the patient choose. I love that. Yeah.
Hello. Oh, great. Two questions, if I may. The screening tools, are those being considered to be made available to caregivers of CF patients?
I'm sorry, I just need some clarification of the promise screeners that I talked about.
Oh,
Yeah.
of the screening tools that we saw today, are they, or are there? Does anybody know of screening tools that are being developed or made available for caregivers of children with CF? Or yeah.
Yeah. I was just going to say, I know in our center we have screened adults with exactly that, the GAD7, PHQ9.
Okay. And are there CF specific versions of those for caregivers, maybe?
Not that I'm aware of.
Okay. Okay. Second question. So I have two daughters with CF. My oldest is 21. I really appreciate the idea of cognitive fusion. As soon as you said that, I was like, oh, that's what's exactly going on with my 21-year-old. With that, she really struggles with her identity. Specifically that cognitive fusion of, what does it matter? I'm going to die anyway. And so I feel like she never, in her adolescence and teens, she never asked those identity development questions, like, who am I? What am I going to do? What does my life look like? Because she just didn't think she was going to have one. And so from the screen, a couple of things. So from the screening tools perspective, are there questions that would tease those things out? Is a teen having proper identity development? Is an adolescent going through proper identity development, knowing that these heavy existential questions coming down on them, even in their, 10, 12, 14 years old, they're being faced with their mortality, right? So are we asking those questions, or could we ask more of those questions?
So ADAPT CF does address some of that. Are you sharing emotions with people that you care about in the way that you want to? And so it's really talking about both getting information and then sharing information to the degree that they want. Now, there is a variability in there, and I think it's hard for adolescents. Some adolescents might say, yeah, I'm sharing nothing, that's what I want. But it also may make them think, should I be sharing information? And those open-ended questions are great for talking about that. Like, who would you share information with? When would you want to? What might be the benefits of it? And I think it's so important in adolescence to think about that as well. And as a child, too, part of child development is figuring out who you are and your support system as well.
Right,
Yeah.
right. Because,
Yeah.
I mean, and I think another interesting research would be the effect on the emphasis on treatment adherence on identity development and, mental, that. Because I think that's where my daughter's cognitive fusion came from, was do your meds or you're going to die. And she's like, oh, I guess I'm just going to die then.
And I appreciate your question so much. Thank you for sharing that.
Yeah, so just some thoughts. Thank you.
No, thank you very much. I just wanted to add one thing in reference to your first question. Dr. Adrienne Alpern at CHOC, and the reason I know this is because we're a sub-awardee for this study, is developing a measure of caregiver risk and resilience, and that's being done now. And so hopefully in a couple of years we will have something more along those lines.
I was just going to add to that in the CF palliative care guidelines, there is a screening tool for caregivers. It's called the BASC, and it's focused on the positive and negative aspects of caregiving, but there's definitely opportunity to kind of focus on those like rewards of caregiving. It's a very normalizing tool. We've used it along with the ADAPT CF at our center. So if you're looking for something else, it does include emotional components, so you could pair that with the GAD or PHQ-9. So just to put that out there.
Yeah, thanks, Shannon.
Okay, going once. All right, so thanks everyone. You've been a great audience. Thank you again to the presenters. Appreciate your time.